My name is Duk-Woo Park, D.W. Park, from the Asan Medical Center. So I'm gonna very happy to discuss our ADAPT-TAVR trial will be presented the ACC 2022 late-breaking clinical trial. Yes, so our ADAPT-TAVR trial has a very important study hypothesis. On the basis of current available data and the subclinical leaflet thrombosis after TAVR is a really issue in daily TAVR practice. What is known, what is unknown? Usually we know the leaflet thrombosis and if you're gonna use the oral anticoagulation rather than the antiplatelet therapy and the significantly reduce the overall incidence of leaflet thrombosis. However, we don't know the causal relationship of leaflet thrombosis and the cerebral thromboembolism. Also, we don't know, and if you're gonna use the oral anticoagulation rather than antiplatelet therapy, the OAC can reduce the leaflet thrombosis associated cerebral thromboembolism, also stroke or TIA. The study is just targeting the TAVR, the recipient and the patient who underwent successful TAVR procedure, also without any clinical indication for long-term use of oral anticoagulation, such as atrial fibrillation. So, and we include 220 patients, and the randomization, one arm is Edoxaban 60 or 30 milligram once daily versus the other arm is dual antiplatelet therapy, aspirin plus clopidogrel. When we enrolled the patient at the time, the aspirin plus clopidogrel was the default recommendation strategy. So our trial included nearly 220 patients. And we defined the primary clinical endpoint, and at 6 months, a CT scan, we defined the overall instance of leaflet thrombosis between two groups. Also, key secondary endpoint, we measured the serial MRI at baseline and 6 months follow-up. Also, we measured the neurological and the neurocognitive function test at baseline and the 6 months. Also, we measured echocardiographic parameter and any clinical event, the bleeding or the ischemic event between two groups. So our key result is very interesting, and the primary endpoint of leaflet thrombosis and the Edoxaban group at 6 months occurred 9.8%, and the dual therapy group, DAPT group, occurred 18.4%. ITT population p-value was 0.076. We did not achieve the statistical significance. And PP per protocol analysis, Edoxaban group leaflet thrombosis incidence 9.1%, and the DAPT group 19.1%, and the p-value was 0.047. In PP population, we achieved the statistical significance. The key secondary endpoint, and we evaluated MRI, serial MRI finding, and between two groups, the presence of a new cerebral lesion on MRI and occurred 25% in Edoxaban group. In DAPT group is 20.2% in DAPT group. We didn't find any difference, the new MRI region. Also, we did not find any difference overall number of total new region, overall volume of total new region. Although we achieved some significant reduction of overall leaflet thrombosis with Edoxaban rather than DAPT therapy, and the leaflet, the new cerebral lesion on MRI, absolutely no difference at all. Also, we measured the neurological and neurocognitive function between two groups, and the worsening of NIS scale. This is a conventional neurological endpoint. Also, worsening of a modified Rankin scale and worsening of a Montreal cognitive assessment, absolutely no difference between two groups. Also, another key finding, we did not find any causal relationship, any significant association between the HALT and the leaflet thrombosis severity and the new region on brain MRI. We did not find any causal association. Also, we did not find any the association and the leaflet thrombosis severity and the neurological assessment outcome like NIS, modified Rankin scale, and Montreal cognitive dysfunction. I think our trial has a very important clinical implication in daily TAVR practice. And the first, leaflet thrombosis has not been proven to affect clinical outcome for TAVR patient, and therefore this imaging phenomenon should not dictate antithrombotic therapy for its prevention after TAVR. And second, the absence of evidence of temporally related adverse clinical sequelae of imaging detected subclinical leaflet thrombosis absolutely does not support routine imaging screening tests for detection of this phenomenon. Also, imaging-guided antithrombotic strategy in case without hemodynamic or clinical significance should not be recommended. Yeah, I think it's the take-home message. We found some class effect if you're gonna use the oral anticoagulation like Edoxaban. Our previous study, Rivaroxaban, also the Atlantis Apixaban shows the overall incidence of leaflet thrombosis. However, we did not find, although we achieved the lower incidence of leaflet thrombosis with the oral anticoagulation instead of antiplatelet therapy, it does not associate any reduction of the thromboembolism on MRI and any change of neurocognitive dysfunction. So our finding absolutely support and the current guideline, updated guideline in European guideline and US guideline, and the poor patient without any indication of the oral anticoagulation, the single antiplatelet therapy or aspirin monotherapy should be the choice of treatment after TAVR procedure.